Hello, everyone. Thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will also be made available on our website under the Education tab. I'll post the link in the chat along with the short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder for upcoming LHS events, the next seminar will be on March 4th with Dr. Charles Friedman. And with that, I will turn it over to Dr. Genevieve Melton-Mew to introduce our speaker.
Hey everyone, good afternoon. It is my distinct pleasure to introduce today's seminar speaker, Dr. George Hripcsak from Columbia University, where currently he serves as the Vivian Beaumont Allen Professor in the Department of Biomedical Informatics. Previously, he also served as their department chair for over a decade. Dr. Hripcsak's research focuses on important informatics challenges, including clinical phenotyping with real-world data, leveraging nonlinear time series data, knowledge engineering, machine learning, and natural language processing, observational research, including that which bridges phenotype and genotype, and increasingly the exposome, and broadly the area of electronic health records and automated decision support. Notably, George has served nationally as the co-chair for the Meaningful Use Work Group, which was funded through and sponsored through the Department of Health and Human Services, Office of the National Coordinator on Health Information Technology. He led efforts to create Art and Syntax, a language for representing health knowledge that has become a national standard with decision support, and also leading the Observational Health Data Sciences and Informatics, or OHDSI efforts, including specifically its coordinating center. He'll talk a bit about that today, but just to give you a prelude, OHDSI is an international network with thousands of collaborators from 83 countries with health records on almost 1 billion unique patients. Also, he's involved with national efforts in clinical phenotyping with eMERGE. He's the PI on Columbia's Regional Recruitment Center for All of Us Precision Medicine program. He's been recognized nationally and internationally. He's a member of the National Academy of Medicine, the American College of Medical Informatics, and the International Academy of Health Sciences Informatics. And amongst numerous accolades, in 2002, he was awarded the American College of Medical Informatics Morris Cullen Award of Excellence, which is considered the highest honor in the field of informatics. George is an outstanding mentor and teacher. His motto in developing trainees and faculty at all stages of their career and staff is to do the good work. His impact has really reached far within the field of informatics and beyond. So we're thrilled to have this time with him at this month's Impact Seminar as our speaker, as he discusses drawing reproducible conclusions from observational clinical data with OHDSI.
Thank you so much, Genevieve. Let me just did that work? Are you looking at the right screen?
Yes.
Okay, thank you. Hi, thank you so much again, Genevieve, and thank you for inviting me. And it's fun to give this kind of talk on the learning health system. So and I have no financial disclosures. Let me get right into it. My style is I have a lot more slides than I actually use, and I kind of whip through it and see how that talk feels and what I should focus on that time. So don't worry if it's flying by a little too fast. I kind of use it as a backdrop for a narrative. So what I mean by observational research is subjects are observed in their natural settings, also known as real-world evidence, as opposed to, say, randomized clinical trials. And we use administrative claims databases, electronic health records, and other sources of data. Healthcare is a $5 trillion industry. NIH doesn't have the money to duplicate that. We need to learn from the billion visits that we do a year in the country. And we do need to do it. If this is a graph or a chart of all drugs in the world on the left side and all outcomes, I don't know, 40,000 on the top. And there's a dot wherever we have evidence. So this is a mostly white chart, meaning that when a doctor gives a drug, they don't know what side effect it's going to give. We test for certain side effects that we suspect, and we stumble on side effects that are very common, but we miss side effects that are still potentially important, but not so common. So there's a huge gap to fill in a rectangle like this. This should be a red rectangle. And institutions now have databases with 1 million or more people, and it seems like we can do research with that. But even with a database of 2 million people, how many of them have the disease you're interested in? How many are on the drug? How many had the side effect? By the time you're asking all those questions, you're down to 10 patients and can't really do a study. So one thing you need to do is large databases, not 1 million, but closer to 1 billion. But there's a catch in all this kind of research. Here's 2 papers a month apart on the same database for the same question. And one says, yes, it causes esophageal cancer, and the other one says, no, it doesn't. Now, if you look at it carefully, the confidence intervals aren't really that different, but the public reads this and doesn't know what to do with it. How can 2 top researchers and top journals on the same database disagree? And we've all seen through COVID retracted papers and questions of validity of research. So that we end up with editorials like this that say, we should just do randomized trials. We really need to de-emphasize observational research. But it's a false comparison. We're never going to do the randomized trials we would like to do. We're not comparing observational research to randomized trials. We're comparing observational research to expert opinion and instinct. So isn't it better to add evidence, try to make it as reliable as possible, and improve those decisions? As you'll see later, guidelines, which are said to be evidence-based, if you look at the details and count the number of recommendations, they're actually still mostly expert opinion, not based on evidence. So we can create a framework, and this is by Patrick Ryan, for how we produce more reliable research. And I'm going to go into this in detail later, so I won't piece through the slide, but I'll just say now that answering all these questions actually takes community. And that's why we created this community, which is Observational Health Data Sciences and Informatics, known as OHDSI, whose mission is to improve health by empowering a community to collaboratively generate the evidence that promotes better health decisions and better care. It's an international effort with a coordinating center at Columbia University. Here's our 4,200 collaborators that are in our Teams environment. I mean, I would say like 500 or 600 are active at any given moment, but 4,000 are defined there. They come from 83 different countries, most of the continents. And in the last 10 years of our existence, they've published 700 papers with explicit influence on the FDA and EMA, European Medicines Agency. Now, OHDSI carries a data model called OMOP, Observational Medical Outcomes Partnership. And we counted 544 data sources used our common data model. And 974 million, almost 1 billion, unique patients have had at least one of their records converted to the OMOP common data model. And that's 12% of the world's population. Now, OHDSI is a voluntary effort. How do you get so many patients in your database? Well, you don't. You create a federated database. You leave the data where it sits. You convert it to a common data model. And then we distribute the analytics over GitHub or even email sometimes. They run the analysis locally. They send back the results. And then we come together and collaboratively interpret the results and publish together. Our papers often have many authors representing all the people who played a part in that study. So just like when you bring an appliance around the world and you'd like to plug it in and it doesn't fit, OMOP serves as a common receptacle so that the data, which come from different sources and are in different languages, because remember, we're covering most of the continents. Actually, we covered all 7 continents, to be truthful, because I managed to get one person from Antarctica to agree to be part of OMOP, but then when he left, his successor never answered his email, so we're back down to 6 continents. But anyway, we use a standardized format, which is shown here. So this is the data schema for the OMOP common data model. It's a deep information model. We try to keep it simple so that you can understand it. There are things like drug exposure, procedures, devices, measurements are where the labs go, conditions are where the diagnoses go, visits, and so on. Then we need to populate this thing. We do that with the vocabulary. So what we do is we accept all the vocabularies that we can get our hands on. Right now, we're up to 143. Actually, maybe 149 since the slide was made, now that I think about it. 11 million concepts with 86 million concept relationships. It probably costs around $1 million a year to maintain this vocabulary, which we get sources for in various ways. And what we do is when you have a code from your country, we convert it to the standardized centralized vocabulary, which is made up of SNOMED CT, ARCS norm, and LOINC, and a couple others to covering other areas. Sometimes people worry about OMOP. You know, I'm converting my ICD-10 codes into SNOMED. Is that a good thing? Don't I lose information? Well, we've done studies on that, and we found taking phenotypes from the eMERGE effort that they're basically identical. 4 were literally identical. The cohort that was generated, and 5, the error rates are less than 1%, and no effect on the estimated effect hazard ratios, odds ratios, or anything. So there's a problem. Observational research is difficult. The mapping is not causing that problem. We've been working, you know, you can't do a talk without, so I'm actually avoiding talking about large language models and AI in this talk and trying to stick with the health services, but we are working on reducing that $1 million price tag by using large language models to help us maintain the vocabulary, for example. Now, anyone who works in standards know you give someone a standard and a bunch of data, and you give it to 3 people, and you get 3 different versions of it. Because even though there's a standard, there's always some ambiguity. So a lot of our work goes into the conventions by which we convert data. For example, if someone dies, what was their cause of death? Was it the heart stopping, or the sepsis they got at the end, or the cancer? And so you need to work out what you're going to put where. And our Themis work group works on those conventions. We give you tools to convert your data to the OMOP Common Data Model, tools to check the quality of your data. And so we end up with this large database. Then the raw data are not quite enough. We need to do something else, and we call that phenotyping, which is a term that we stole from biology. When I teach the medical students, I joke with them and I ask them, what does PERLA mean? And they usually say, well, pupils equal, round, reactive to light accommodation. I say, I didn't ask you what it stood for, I asked you what it meant. And some of them who have been on clinical rotation start laughing because they recognize PERLA in the chart just means that someone looked in the patient's direction and they had 2 eyes. And I purposely show a figure here, which is a woman who has 1 eye with a prosthetic eye. And we do find patients in the chart who are PERLA, but which can't be true because you can't have equal pupils if one of them is not there. The data are mostly missing. When someone says they have a 5 million patient database, 1 or 2 million of those patients are single visits, like shown on the lower right over there, where someone came into the emergency department for, say, a broken finger, were never seen again. You can't do much research on that. Accuracy is always a problem, as we've known for a long time. We found that 1 in 2 to 300 notes are on the wrong patient, and worse than that, same for the orders. For the institutions that do interventions to reduce that, that's the ones that get into the 1 in 300 to a little bit more than that. And the data are complex. If I ask you what time did something happen, there are many different versions of that. And healthcare itself is a big feed-forward network that causes bias. The biggest thing is I only measure people when they're sick. If I'm doing a study and I need to know what's happening in between their illnesses, I don't have any data on that. And the result is bias, as shown here. This is a replica, a fine study of community-acquired pneumonia. And the bottom line on this slide, it shows that the healthiest patients, according to my health records, were dying frequently. Why was that? Well, because the patients who came in and died immediately because they were so sick had no symptoms recorded in their record, because what doctor is going to waste time recording symptoms to someone who just came in and died immediately? So they look healthy until their time of death, but they're actually were among the sickest in the database. But the good news is that doctors successfully infer patient state from records. So we need to be smart about how we do this. Phenotyping is a process where we create this intermediate state going from raw EHR data to a phenotype, and then from there we do our analysis. And we can do that with manual work with rules, or we can do that with machine learning, AI, etc. So if we want to know who has type 2 diabetes, I don't just look at a diagnosis code. I see What drugs are they on? What blood tests have they had? What procedures have they had? And then I infer whether they really are type 2 diabetes or not. OHDSI's created a pipeline to help you do this. It's a set of tools that I won't go through in detail. I'll point out that there's a tool to help you search the vocabulary to find the terms of interest, for example, the diagnosis code for diabetes. But then we have a tool called Phoebe that goes around and looks for other terms that you likely missed. For example, there are terms in the vocabulary that say some other disease due to type 2 diabetes. And if it's due to type 2 diabetes, then that's evidence that the patient has type 2 diabetes. So perhaps we want to include that other term in our list of codes that mean type 2 diabetes. We have a tool to help you semi-graphically assemble the logic, like the timing of the phenotype. And then evaluation is the bane of phenotyping, where you have to ask clinicians to sit down and read charts and say how accurate the phenotype is. And we've created tools that semi-automate that process. And then when we make phenotypes, we try to share them. So that's what we do on phenotyping. And then we, of course, help you do the analysis and show the results. So now in the next part of the talk, I want to talk a little bit about the impact of this system. Like, do we have a learning health system? OHDSI generates three kinds of evidence: clinical characterization, which is counting things. How often does something happen? The second is population level estimation. That's what we usually think of when we talk about a study that tests a hypothesis. And the last is patient level prediction of individual patients. So I'm going to talk about a tiny bit about the first one and then mostly about the second one. So first, let's go to that characterization. You know, what drug you take depends on a lot of factors. So we said, well, what treatment pathways do people take for common diseases? So we did a study on 12 databases from 5 countries and published it in PNAS. And what we did is we said for 3 diabetes, type 2 diabetes mellitus, over a 3-year period, what sequence of drugs do people take? The inner circle is the first drug, then the second drug, then the third drug. And if there's nothing outside the circle, then that's the only drug. And what we see here is metformin is taken 3/4 of the time around the world, and then followed by some other drugs that you may have heard of. Now so that's kind of the key for the next figure. So here's the 3 diseases: diabetes, hypertension, and depression. The left column is diabetes. There are 12 databases. I'm only showing 3. All the databases show high use of metformin, except the last one. The first 2 shown on the screen are US and UK. The last one is Japan. You see, they don't use metformin very much. We talked to a diabetologist in Japan, and they said Japanese doctors don't believe their patients get much insulin resistance, so they don't use much metformin. Whether that's genetically true or not, I don't know, but it's having an effect on how they order drugs, so we see that difference. The second line is hypertension, all in the US. That has similarities across them, but not quite as similar as the diabetes one. And on the far right is depression, where there's no agreement among those 3 US databases. And that's because we don't have much agreement on which drugs work best in which patients. A fun fact is that 25% of hypertension patients took a sequence of drugs, 1 to 2 to 3 to 4 to whatever number, that was unique in this population of 250 million people. So people are not following guidelines according to that. So we showed with this study that network research is feasible and stakeholders were willing to share their results, and we were able to accommodate vast differences in privacy around the world. So now we get to population level estimation. So first, just showing you some of the problem here. So this is a slide to explain the following slide. The purple is, so this is a graph of the effect, like hazard ratio or odds ratio. And the vertical axis is the standard error in that thing. And if you plot that, the purple on this slide is not statistically significant, and the left and right are statistically significant, with a division where p equals 0.05. We parsed 30,000 studies in the literature. What we see here is this odd shape. It should be a cloud, but it's devoid in that middle V shape, which means that there's severe publication bias, which we know about in our literature. We also see some evidence of p-hacking, where studies that had a p-value of 0.051 and were not statistically significant, such that they probably wouldn't get published. If you just keep working on it, you can find an analysis that will give you 0.049, and then you can publish your paper. And so we see evidence in our study. And this slide just illustrates that it's not just that we're, some people say, well, that's not surprising. We only study the things we think will be positive. And the red line is what you get if you know what's positive. And the blue line is what we see in the literature. And we see cliffs at p equals 0.05. That can only happen with external bias. So individuals may do good studies, but in aggregate, the medical observational research system is basically a data dredging machine. So OHDSI created something called Legend with 10 principles of how to create reliable research, which I can summarize with this figure. And basically, you want to have an open system and a verified system. Open means pre-specified protocol, so I can't cheat. All my software is open source, so you can check my results. Diagnostics have to be checked before I'm allowed to see the results, and then I publish everything so there's no publication bias. Verification is at every step of the process. So I have diagnostics all the way down the process, the database, the phenotype, the analysis, and so on. So let me go into some details about those processes I'm talking about. The first one, and this is where I'm going to slip over some slides. Let me see where I am. The first thing, the bane of observational research is confounding. That is, for example, if I'm studying whether butane gas causes lung cancer, and I do a simple study, I'm going to say, sure, it does. Everyone who's carrying a butane lighter is getting lung cancer. Something must be wrong with it. But of course, we know that people carry butane lighters probably because they're smokers, and smoking causes lung cancer. So smoking is a confounder that affects our estimate of whether butane gas causes lung cancer. When we do observational research, we need to correct for this. There's a technique that's been around for 40 years called propensity score adjustment, invented by Rubin. And what it does is it balances the two groups you're comparing to make them look as if you did a randomized trial. And the way it works is, again, this is that I'm going to go here. You select a set of confounders to adjust for to make sure that the two groups are well balanced. Now, what we see here is, how do you pick those confounders? Usually manual selection. The researcher sits down with a clinician and they sit and say, what could possibly be affecting both my treatment and my outcome, the way smoking affected both butane gas and lung cancer. Here I've taken 5 studies that study the same hypothesis, and you see 5 distinct groups of confounders. In each of those studies, the researcher said, I know what the confounders are, and here they are, and we're going to do my study. But only one of them can be right. There is overlap among them, but it's imperfect overlap. Some people do an empirical selection, but it's also subject to bias. So what OHDSI does something different and unique to OHDSI, which is large-scale propensity score adjustment. So what we do is, instead of picking the confounders and including them, what we say is, let's take all the variables and adjust for them and throw out the bad ones. And the bad ones are mediators, colliders, instruments, and things like M-bias. And then we are assured that we will have the confounders included there. We use something called lasso regression, which is a regularized regression technique. And we do that because we may have 60,000 variables, but only 10,000 cases. And you can't estimate the coefficients for 60,000 variables when you have only 10,000 cases. So lasso helps us get through that imbalance in information. And then given a propensity score, you do matching stratification or weighting techniques to balance the two and make it look like a randomized trial. So I said we have 2 groups, and we're trying to have a randomized trial. If we were to randomize, the 2 groups should look pretty similar, and then one gets treatment A and one gets treatment B. When we go to do an observational study, before we do our balancing, we find that the 2 groups often differ because there's different reasons why the person got treatment A versus treatment B. After we do our adjustment, we find that the 2 groups look very similar. So here, this curve, this graph shows on the x-axis is their differences before matching, and the y-axis is their differences after matching. And we see that all the variables are less than 0.1, which is the industry standard for saying that it's sufficiently balanced. And we're not just less than 0.1, the industry standard, but we mostly below 4 times smaller than that. And we also just make sure that the two groups that we're comparing before adjustment are similar enough that the comparison is valid. Explaining this kind of concept would be an hour talk in itself. I'd like to move along and do some additional topics. Now, what you will hear, what we've gone through when we publish a paper, sometimes people will question our methods. For example, they'll say, well, I'm glad that you included confounders, but there are other things called instruments that could hurt your analysis and add to your bias. And my point in including this slide is just to say that we've done the analysis that shows that our diagnostics confirm that there are no strong instruments, and if there are weak instruments, they don't have an effect, a sufficient effect on the effect estimate that we're estimating. That is, does one drug cause something more than another? And then here's a fun thing. I'm going to go right here. Now you say, well, that's fine, but observational research is always flawed because there's unmeasured confounders. So things that you didn't happen to measure, and they're important things. It could be like economics, education, genetic factors that I didn't measure. What we find is that when we include many variables, that these other factors are correlated with the variables we did measure. And here's an example. When we did our large hypertension study, most of our databases didn't have measured blood pressure. And blood pressure is a confounder for studying hypertension drugs, baseline blood pressure before you started the drug. But what we found was when we balanced on all those other 50,000 variables without having any vital signs, we also balanced the vital signs and made the two groups identical to each other and got legitimate answers. I'll go through this part now. Yeah. The second thing we do is we don't trust everything I just told you. So we say, yeah, we did this correction for confounding and we think it's good, but we don't trust that. So we do negative control. So in addition to the hypotheses we test that we're trying to test, we pick other hypotheses where we think the answer is no, based on other evidence. And those are called negative controls. So for example, I'm comparing two drugs and which causes more renal failure. Well, I'm going to say, well, neither of those drugs causes an ingrown nail. Let me see if my study shows that they do cause an ingrown nail. If it does, then there's something wrong with my study. There's bias, like unmeasured confounding, that I need to control for. But we don't do one negative control. We do many negative controls, a whole population. So here's, remember, this is the kind of figure I had before. And I have a test of two depression drugs, and whether they cause ingrown nail. It appears that they do. It's statistically significant right now. Once I do my confounding adjustment, I get an answer that's p is 0.44. So this one is good. And I then do, say, 50 to 100 negative controls, and I plot them. And I find in this case, I want 5% of those negative controls to be positive just by chance alone. We get, if we do a crude estimate, we get 68% are positive. So then when we do a propensity score correction, we get only 16%. And then we do calibration to bring it back down to the 5% we were looking for. So that's what we do with that one. Another thing we do for reliability is use multiple databases, practice types, and locations so that we can triangulate the result and confirm it. Fourth thing we do is as I said, we're open, we publish everything. And the fifth thing we do is we test many hypotheses at scale, not just many negative controls, but many hypotheses. And when we do that, we got the cloud that I was hoping for rather than that V-shaped thing that we get in the literature. So now let's take a real example. Hypertension is an important area. The guideline says there are about 30 drugs you should use and 30 drugs that are kind of second line. That's based on just 40 randomized trials. The circles, the dots around the circle are the drugs. The arcs are where we have real evidence. So any conclusions about any of the things that don't have an arc are just expert opinion. So we did a study, and when you do hypertension treatment, often you use two drugs. So we compared every pair of drugs to every other pair of drugs, or 10,000 comparisons for 500,000 hypotheses, because we had 58 outcomes. This was the randomized trial that we mimicked. 58 outcomes of interest, 76 negative controls, 9 databases, and came up with this answer. The randomized trials among these classes of drugs, ACEs, ARBs, beta blockers, calcium channel blockers, and diuretics, the randomized trials didn't distinguish them. But our study, called Legend on the right, found some differences. It found that beta blockers are actually second-line drugs. And that confirms what was done in the guideline, even though the randomized trials didn't show it so simply. Here's a breakdown of the first and second-line drugs. The square on the upper left is mostly gray. It means that the first-line drugs are approximately tied. The green square on the upper right and the purple square on the lower left say that first-line drugs really are better than second-line drugs. And the square on the lower right just means some second-line drugs are better than others. What this means is that the hypertension guideline pretty much got most of it right. But I highlight one part. It says that chlorthalidone is a diuretic and it's preferred over other drugs like hydrochlorothiazide based on a couple of things. I'll just highlight this example because it's an example of going through, learning health system. So hydrochlorothiazide is a diuretic. It's the most used in the world. Chlorthalidone was actually on the original Beers criteria, which said old people shouldn't take it. It actually was on the candidate list, and it just missed being included in the list. But, physiologically, chlorthalidone is stronger. It lasts longer, and it's a little more potent. And so even though doctors use hydrochlorothiazide, researchers feel, well, maybe chlorthalidone would be preferred because it's stronger. And they did something called an indirect meta-analysis that maybe favored chlorthalidone, although there were some issues with that study. And then recently, there had been an observational research study in Canada, a great study that showed that hydrochlorothiazide was better. So we set out to try to see if we could answer this question. And we did a study published in JAMA Internal Medicine. It passed the diagnostics. It said they're equally effective, but that hydrochlorothiazide, the one that people actually use, is a safer drug. Less kidney failure, less hypokalemia, and so on. We published the study, and it got lambasted in the literature. The researchers said, no, you should use chlorthalidone. Our study is probably biased. Just ignore it for now. Wait 2 years. There's a huge randomized trial coming out. That huge randomized trial comes out in 2 years. It shows the same thing. Not effective. No difference in effectiveness, worse hypokalemia. They didn't find the kidney disease, but they had 1/10 the patients we had. Even with this randomized trial, the editorial in New England Journal said stick with chlorthalidone, despite evidence against it in the randomized trial. So where we stand today is 3 other studies have come out since then, also saying that they're equally effective and hydrochlorothiazide is safer. But still, the researchers want to stick with chlorthalidone, which shows that even when there's evidence, even as randomized trial, it's hard to convince people. The good news is the 2023 European hypertension guideline came out, and it kept hydrochlorothiazide as an option, whereas the 2024 that was the hypertension guideline. This is the cardiology guideline, actually says just do chlorthalidone. So we still have some work to do, but luckily, practitioners still favor hydrochlorothiazide, which I think is the right drug. So you can see that it's not a simple thing of just doing a study and then answering the question. On the other hand, when people are behind you, when you give people something they already believe in, then it's easy. We showed that ARBs are better than ACE inhibitors for treating hypertension. Published in Hypertension, JAMA News published that. And then Circulation had an independent editorial saying, okay, this study does it. We should change the guideline. So we took our data and said, well, are we matching the RCTs we could find? And in fact, on 28 out of 30, we gave the same answer as the RCT, which is the number you'd expect, because a p-value means we should be off by 2 on average. And we filled in the evidence gap. That previous figure that was sparse is now full. And we've published other papers in hypertension. Now I'm just going to go through, actually very quickly, some other evidence. So this will just be a couple more minutes. We've also done a paper we've moved now to type 2 diabetes mellitus, second-line drugs, produced an influential paper. COVID, we published a lot of things, trying to get hydroxychloroquine not used anymore, which was successful with the EMA and FDA. Working with hypertension drugs, it's safe to take them despite chlorthalidone. We were the ones who did the study in Europe in 2021 that said that AstraZeneca COVID-19 vaccine should be turned on again for 700 million people. The EMA asked us to carry out a study. Just to point out some collaborations where else we're working. We work with the FDA, biologics. So we're mostly focused on the biologics initiative. So things like vaccines, and have been doing methods research for them. The All of Us research program uses our database. The eMERGE network uses the OMOP common data model. N3C uses the OMOP common data model. And Europe is very strongly in it. The EMA, a 30 million euro project, which is then turned into the Darwin Initiative, which is basically the European Medicines Agency is the EMA, their evidence network. And Korea, for just as an example, Korea adopted OMOP as its national infrastructure. So there was a paper, Genevieve is a co-author, doing an analysis of the various networks used in the US. And this, where you want to be is in the upper right corner of best use times value. And Odyssey scored a 20, the second highest was a 14. So it is a well-used data model. And we're doing some other work, but I want to get to answer, let me see where we are. Yes, perfect. I want to get to answer some questions. So in summary, current observational research is suspect. Large-scale observational research appears to be possible and more reliable than current approach. Large-scale evidence generation on a voluntary international network is feasible, and I think we can achieve reliability, and a major leap in evidence availability is possible. Here's the team that worked of it, trainees and Odyssey collaborators and causal inference collaborators and funding. And I will stop there.
All right. Well, thank you all. We have about 12 minutes remaining for the Q&A. If you have questions or comments, please use the raise your hand feature. We also welcome you to type your questions into the Zoom Q&A. All right. It looks like Carolyn has a question. Carolyn, you should be able to speak now.
Yeah, thank you so much. That talk was really amazing. Sorry, I'm not on video. I guess I could be, but two questions for you. You mentioned working with the FDA. Have you seen them, or you mentioned working a lot with guidelines, and guidelines can make recommendations without label changes. Have you seen the FDA make label changes based on observational analyses?
That's a good question. So first of all, let me point out that, as I mentioned, what we do for FDA is do methods research, and then they generate the evidence. So they have to be careful not to do studies that they don't have strong control over, because an inadvertent, an incidental result then has to be followed up in various ways if the FDA generates it. So we do is we help them what methods they should use, largely on the vaccine safety side, and then they went ahead with their side. Now, they do use papers to make certain decisions, like some of the vaccine decisions they made and the hydroxychloroquine decision. The FDA doesn't publish how they made their decision, but the EMA does publish it. So there we can see the explicit papers that they use. So we know that the EMA used this evidence for the decisions about hydroxychloroquine and ACE inhibitors and ARBs and things like that. The FDA, they just come out with their decision.
Thank you. That's great. And I love your emphasis on sort of just repetition and across different data sources. I feel like that's really important, because even clinical trials can have measurement error, or using an unvalidated definition for an outcome. So anyway, thanks for the great talk.
Thank you.
All right. It looks like we got another question in the chat. It says, thank you for an excellent overview. The OMOP CDM has become a de facto standard in healthcare research. What enhancements or additional capabilities do you wish existed in either the data model or the OHDSI analytic infrastructure?
Sure. Thank you for the question. So first, there are a lot of things we'd like to do with our data model, but when you have 1 billion patients in it, you have to be careful how quickly you want the entire world to move on that. So we're now a victim of our success. Furthermore, we've generated millions of lines of code, and if we change the data model too much, then then the code breaks and we don't have the people to change all the code too quickly. So we had a lot of changes quickly in our early history, and now we've slowed down very much. We're planning a version from 5.4 going to 5.5 in 2026, but they're not major changes. They're the changes that are most useful to the user community while not generating $100 million worth of changes around the world. So examples are, we have a way of storing dates and times, and we want to just go to a timestamp, but that would break all our code. So that was version 6, and actually we went to version 6, and then we backed up to version 5 because the community could not take it. So we will get there, but just not immediately. And there are stupid things like fields called gender instead of sex that are off, and the reason we haven't fixed it yet is because we can't rewrite 1 million lines of code so quickly. So we have to put up with some things, in the interim. On the analytics, the funny thing is we started off trying to build analytics to help people who knew nothing about research to do research, and that doesn't work really. And we realized what our best way to move the field forward was to go to people who are very experienced with research and make it much faster to do more studies for them, and have people who don't know research first learn how to do it and then come in. And so our tools are not meant for someone to just walk in and then publish the study in JAMA the next day. We would like to, be halfway there and build a set of tools that pulls people forward in doing research. And we're working on it. But again, it's just a limitation of funding and so forth. We're not a major funded, we never have gotten a large grant from the government to do OHDSI. It's been pieced together from various parts from government and industry and around the world. And so my job as director of the coordinating center is mostly to raise money to fund things like the vocabulary and our tool building. So the answer is yes, there is much we would like to enhance, and we're just limited by our resources and just practicality. Even if we had the money, I need everyone who has all those databases to be able to make those changes with us. So we have to go a little more slowly than we used to.
All right.
But, actually, the thing that I think has made OHDSI successful is our mission statement, which actually, we spent a lot of time on that. And we say it every time we start a meeting or start anything, to remind ourselves our job is to generate evidence to improve health, not to build the data model. So nothing happened, it's like some people really wanted us to, if a person didn't answer a question on a survey, did they say no? Did they refuse? Or did we forget to ask them? And we're like, no one is going to use that for research because no one ever puts that in accurately anyway. So we're not going to spend our time coding that. We're going to just have, some form of no as the answer. So we're always driven by the use case, and we try to only make the changes that are necessary to improve our generation of evidence.
All right. It looks like Matt has a question. Matt, you should be able to speak now.
Great, thanks. There's so much care and attention given to making sure that the causal inference made is robust. I'm curious if there's, in the methodology work that's happening, is there any benefit to or any interest in simulating complex systems like humans and healthcare are, with feedback loops and emergent behavior, and then testing the robustness of those causal inference methods when you have full knowledge of the system? Is that anything that might be valuable?
I mean, sure, because now remember, OHDSI is an open community and we have our methods work group. So that is where you might come and suggest that. You would then have to do that research because it's a voluntary effort. Yeah, I mean, we do a lot of work in using simulations, but that healthcare process bias kind of thing that you're alluding to is not something we've simulated as part of OHDSI. I've done some work in that outside of OHDSI. But yes, we'd be interested in looking to see how what kind of biases are coming about because of that we might be missing and not correcting for.
Thanks.
All right. It looks like we got another question in the Q&A. It says, excellent presentation. I'm wondering about your own thoughts regarding the emergence of availability and usability of continuous or near continuous data obtained from evolving digital digital devices. So, for example, blood glucose, sleep parameters, and blood pressure.
For sure. And we have work groups who have been looking at that. There's a device work group and so on. What we tend to do in the core data set is we'll put an abstraction of those data. So we store the data somewhere that makes sense, abstract the concepts out of that, store that centrally, making it easier for the researchers to use it. But we definitely see the need for that. I mean, to be honest, most of our studies have been using just the standard structured data. But if you look at the All of Us research program, I mean, that's more or less what we're doing. Are you doing some devices? And we also have the genomic data, which we've kept separate other than the interpretation of the genomic data, which can be put in the central clinical database, OMOP database, although mostly in All of Us research program, we're keeping the two separate. But I would say, yes, there's a work group explicitly focused on that.
It looks like someone else asked, as a guideline developer, it would be interesting to look at time trends to see if recommendations and payer decisions show changes in implementation or de-implementation. Is that feasible through a OHDSI?
Yes, I mean, for sure. So we do some of this. We would be, if someone is, since Odyssey is voluntary, it's easy to invite everyone in. I mean, it's a lot of work to join Odyssey. I just want to tell you, there's a learning curve and there's a lot of time, but I think the investment is worth it. In fact, anytime we do a study, we do diagnostics, and one of the diagnostics is seeing how often that drug is used over the timeline. So we end up in the process of doing the diagnostics for our studies, seeing exactly that, and we see the drugs go up and down depending on what happened with a black box label warning or a guideline change, or just availability of the drug. Not usually an unavailability of the drug, that can happen, but more just the drug became available. So we see those trends, and we do that purposely because we want the change in the use of the drug to match our belief of what should have happened. Because if it doesn't match our belief, then we think, oh, our phenotype must have a bug in it. For example, one thing that goes wrong is in 2015, we switched from ICD-9 to ICD-10. If there's some big change in the rate of the diagnosis, we're probably got one of those coding schemes wrong. So that's just one example of why we look at these time series. But yeah, we do that all. We definitely do that.
Next we have a question from Ray who wanted to know, what do you see the potential benefits of large language models for OHDSI?
So we've been, so like everyone else, we actually published a paper recently on using large language models for chart review. So what we do is we take the chart, and this is through knowledge engineering, manually turned it into a summary, which we could do with large language models, but we didn't in this paper. Then we use large language model to take the summary and say, does the patient have the disease or not? And it did just as well as doctors in deciding, is it yes or no? So the next step, I guess, would be then do the summary via large language model. Well, I just finished an experiment. I was looking at the results today because someone asked me a question of extracting things from papers from the literature. And it did a perfect job, and it beat the gold standard, in fact, because gold standard had a mistake I didn't realize. So for things like extraction, it does very well. On the other hand, I asked it then to code those things that it extracted, and it got 0% right. It made them all up. So it depends on what task you give it, and you need to have a good evaluation to see whether it's going well. But I have to say, I was amazed at what it did. It was extracting. I wanted to know from each study what confounders were adjusted for. And these were studies that were super hard to do that on, because they were studies that they were looking at both confounders and censoring variables, or they're looking at confounders, instruments, and mediators. Like, that's a complex topic and hard for a person to go through and get. And it got it perfect, as far as I could tell, and one better than the gold standard. So there are, I think, a lot of the knowledge engineering, we're starting to experiment with it. And then the other thing we're doing is generating synthetic databases with transformers. So not actually a large language model, but a large, EHR model, and seeing how well that does. Does it preserve privacy, and can we replicate studies in it so people have better synthetic data sets to work on, and a few other areas. So yeah, we're looking strongly at transformers, large language models, and so on.
All right, I think maybe we'll do one more question. Steve wants to know, How can we get Epic and Oracle to better support OMOP to free our organizations from all of the work we are doing to maintain the EHR to OMOP mappings?
Um, don't invest in Cosmos. That's a joke. So, I mean, Epic feels like it's doing well. It has Cosmos. It has a lot of customers using it. It doesn't use the OMOP Common Data Model. They considered using OMOP, but they decided, and they already have it all in a somewhat similar format because of clarity. So I think that Epic has some work to do on their analytic structures, but as far as creating a database, I think they've succeeded in creating a database. We are not part of Cosmos, our institution itself, but some of our friendly institutions are doing it and starting to do studies in it. So I think as long as they have that avenue, they don't have a big incentive to use OMOP. I think, sure, if enough customers demand OMOP, then it would. But when you demand OMOP, generally they send you to the Cosmos salesman. And Oracle's the other one. I mean, Oracle has done some. I mean, through the companies that got to Oracle, some of them have been OMOP, collaborators and inventors and stuff. So they may not have anything right now to help you, but that one's probably more solvable.
All right. Well, thank you, George, for taking the time to give this talk, and thank you all for attending. Again, in closing, please join us for our next seminar on March 4th at noon Central Time. This concludes our presentation. See everyone next time.